At the back. So my name is Muhammad Azwan and today we have two discussion. One is journal club and one is CME. So my journal club topic is on metformin use and the risk of total knee replacement among diabetic patient, a propensity-score-matched retrospective cohort study. So this paper actually just recently published in the scientific report Nature. So it is very difficult to penetrate Nature. So I bet this paper has actually give us a new knowledge or finding on the management of knee osteoarthritis. So what interests me is the conclusion of metformin that has a chondroprotective effect or potential protective effect on knee osteoarthritis progression and later TKR incidence among diabetic patients. So today I would like to bring you to dive into this journal. So first I would like to talk about metformin. Everybody knows about metformin. So metformin has been widely used in type 2 diabetes. In fact, in the latest Malaysian CPG 2020, metformin is still number one first line treatment for type 2 diabetes in HbA1c less than 10%. So the action of metformin is improving insulin sensitivity at liver, fatty acid as well as in the skeletal muscle. So in liver, it inhibits gluconeogenesis, so it reduces the glucose formation. In the fat level, it actually inhibits the fatty acid production. And in skeletal muscle, it improves insulin sensitivity, thus increase the glucose uptake into the skeletal muscle through the action of GLUT4. So the safety effect or the safety profile of metformin is well known. You can get some gastric pain, diarrhea, but it is well tolerated in most of the patients. In severe cases, you can get like acidosis, but that is very rare. So that is why metformin is still number one, first line treatment for type 2 diabetes mellitus. However, in recent years, they found out that metformin has a big role in cardiovascular disease. It has a cardioprotective effect by reducing the inflammatory stress through the activation of these regulators called AMPK, adenosine monophosphate activated protein kinase, and also it has a renoprotective effect by reducing the persistent systemic inflammation, thus restore the GLP-1R mRNA expression and decrease the high glucose evoked inflammation. So with this finding, we know that the metformin has a novel effect against the inflammation, or it has some kind of anti-inflammatory effect. So the main important thing that you would like to look is the AMPK here, and also the inhibition of the nuclear factor kappa beta. So I will actually dig in deeper in the molecular level. So what is AMPK? AMPK is adenosine monophosphate activated protein kinase, is a regulator for energy metabolism, whereby it stimulates the energy production such as mitochondrial biogenesis, glycolysis, fatty acid oxidation, and also inhibit energy consuming. So most important thing is AMPK causes inhibition of the inflammation through the inhibition of the nuclear factor kappa beta. There are a few factors that cause up-regulation of this AMPK, hormones such as adrenaline, a good amount of exercise, phytochemicals, and also metformin. And they found out that obesity and hyperglycemia cause down-regulation of the AMPK, thus increase the nuclear factor kappa beta. So AMPK act on the ER stress as well as oxidative stress, inhibit the nuclear factor kappa beta, reduce the inflammation, thus lead to the healthier lifespan or longer lifespan. So again, this figure actually shows the importance of this AMPK. So if you have nutrient restriction, fasting, good amount of exercise, and include metformin, it causes up regulation of the AMPK and cause inhibition of the nuclear factor kappa beta and reduce the inflammation. Whereas if you have nutrient excess, you eat a lot, obesity, hyperglycemia, that causes down-regulation of this AMPK. So when there is down-regulation of AMPK, the inflammation will increase because there is increase in the nuclear factor kappa beta. So the role of AMPK is well known up until today, causing the inhibition of the nuclear factor kappa beta. So AMPK also important for energy regulators. Like I said, it increases the energy synthesis, mitochondrial biogenesis, fatty acid oxidation, and glycolysis, which you will learn in the first year when you enter the program. And anabolism, it inhibits the energy consuming such as protein acid synthesis, steroid, and also glucose synthesis. So, like I said, nuclear factor kappa beta is the mediators for the inflammation. So, the role of nuclear factor kappa beta is well known. If you look into the left side of the figure, you can see that nuclear factor kappa beta stimulate the production of the adhesion molecule. So, when the neutrophil want to go into the site of injury, there is migration, rolling, adhesion, diapedesis, and chemotactic. So these are the factors that is important during the process. So nuclear factor kappa beta does stimulate this adhesive molecule. It also acts as a pro-inflammatory. Thus, it is important for angiogenesis and also proliferative phase in your ligament healing, wound healing, as well as your bone healing. So in summary, nuclear factor kappa beta is very important, but excess can cause systemic inflammation. So they look into the relationship between diabetes, aging, and AMPK, and they found out that there is dysregulation or downregulation of this AMPK in patient who is diabetic, atherosclerosis, cardiovascular disease, cancer, and also neurodegenerative disease. But which one causing which one, we are not so sure. It's like a chicken and egg. There is one animal study that looked into iatrogenic chondrocyte injury. So there is a mice study. They take a mice, they cause chondrocyte injury at the knee joint, and they found out that after the injury, there is reduced in the AMPK activity. So when there is reduced in AMPK activity, there is increase in the nuclear factor kappa beta, thus cause inflammation around the knee joint. So this study actually will be elaborated in the next few slides. And diabetes and knee osteoarthritis, there is a relationship between diabetes and arthritis. It's called diabetic arthritis connection, whereby in patient who is diabetes, there is increased risk of arthritis, and there is complication called diabetic arthropathy, as well as they found out that this AMPK can be a novel target for pain treatment in knee osteoarthritis in the future. So this is the animal study that I talked about previously. So they found out that in this study, the AMPK signaling is very important as after the iatrogenic chondrocyte injury, and when they actually administer metformin, they found out that metformin can be chondroprotective in this animal study, as low as 4 mg per day. 4 mg per day. So they also found out that when they perform medial meniscectomy, it can actually prevent the risk of progression of osteoarthritis. So this could be a future study for us in the future. So thus in this study, in this animal study, they conclude that metformin can be a chondroprotective in patient who has knee osteoarthritis. A systematic review of metformin and also knee osteoarthritis also conclude that there is consistent evidence that suggests metformin can be chondroprotective effect, and this can be a disease-modifying agent in the future for knee osteoarthritis. Now let's take a look about the global burden of knee osteoarthritis. As we all know, all the musculoskeletal disease has increased burden for the past 10 to 20 years. The prevalence is around 3,752 per 100,000 population, and incidence is 181. But if you look at this disability, there is 1,000% increase in disability since 1990. Showing that there is a need to find a cure or treatment for knee osteoarthritis because disabilities has been increasing, in fact 1,000%. So in this research, the problem statement is they want to find a safe and effective therapeutic option. Of course, we have Cisadua, we have biologics, we have NSAID, steroid, PRP, stem cell, but the evidence here is still conflicting. So they want to find a safe drugs that can actually modify the osteoarthritis. Although the knee replacement is effective, but it is costly and it carries an operation risk. So we want to find as safe as possible, cost effective possible. So the objective of this study is to test the association between the regular metformin use with total knee replacement in patients with diabetes. So for methods and material, this is a retrospective cohort study. They use the secondary data from the clinical data analysis and reporting system from the hospital authority at Hong Kong. So inclusion criteria is age more than 45 years old and type 2 diabetes, and the baseline data is taken from the 1st January 2007 to 31st December 2010. So after getting a tick, they collect the baseline data and then they follow up the patient, and the follow-up date is from 1st January 2011 to 31st December 2014. And the outcome that they search is the TKR replacement surgeries and also hospital death. So they identify two main groups. One is Metformin user, whereby Metformin user is patient who had more than 4 prescription. So they said that their appointment is around 3 months. So if they receive 4 times prescription of Metformin, so they consider they receive Metformin for the past 12 months, it is a regular Metformin user. But if it is less than 4, they consider as non-Metformin user. So this is a control for the study.
But in regards to that, like for example, what we're talking about here, if patients who have diabetes regularly in Malaysia, they are started on Metformin, right?
Yes.
So when you're talking about non-Metformin user, is it that the patient was not prescribed more than 4 times over that fiscal year?
Yes.
Or is it because it was stopped for some other reason?
Okay, so in this study, the limitation is we do not know exactly what is the dose, what is the indication of the Metformin.
In the case of OA?
In the case of diabetes, we are not so sure. So they said that if you continuously taking the Metformin for the past 12 months, meaning that you have to receive more than 4 times prescription, because their follow-up is 3 monthly. So 4 times 3 is 12. So you have to receive 4 times prescription. If you
this retrospective data kan?
It's a retrospective data. If you receive less than that,
semua patient ni memang diorang ni ada OA dan diorang ada DM.
okay, that is another limitation. OA, they are under-coded. So macam kita we have the ICD-10. They also have their coding, but knee osteoarthritis is not part of their coding. So it is very difficult for them to trace the patient who has knee OA and develop TKR. So this is one of the limitation that I will discuss in the limitation. So after they collect the baseline data, they perform this propensity score matching. I will explain in a few slides more. So they perform this 1-to-1 propensity score matching, and they use the nearest neighbor approach, and if there is less than 0.1, means that the matching is balanced. So before they perform the matching, they identify this baseline comorbid: hypertension, ischemic heart disease, chronic heart failure, lipid disorder, and tobacco abuse. And they identify this co-medication, a group who has sulfonylureas, insulin, paracetamol, and also NSAID, age and sex, and then they perform propensity-score-matched cohort. So I bet everybody is asking what is this kind of propensity score and scale. So what analysis they want to use is they want to compare a big apple to big apple, a small apple to small apple, a mother duck with mother duck, a baby duck with baby duck. So
that is the meaning of propensity.
Yeah, that is the meaning of the rather than you take a whole data and then you compare, and so
Don't compare by statistically lah.
meaning that same group. Contohnya, if the patient has Metformin and sulfonylureas, so they will compare a patient who has Metformin and sulfonylureas only. So that is the propensity matching score analysis lah. So they want to have a almost equal comparison. So if it is more than 0.1, it is called unbalanced. So they will remove that from the data analysis. Okay, so in exclusion, they remove this SGLT2 and GLP-1 because it is newly introduced. So they did not want to introduce this earlier. Opioid and also revision of TKR is considered as complication from the TKR itself.
Why was opioids?
So opioid, I'm not so sure because they do not mention why they are removed. But one of the indication is opioid is not the main treatment in knee osteoarthritis lah, such as morphine. So I believe that is one of the reasons lah. But they do not mention why opioid was removed in this study. So after they got this matching, so they will perform this Cox proportional hazard regression or log regression analysis, and they will identify the hazard ratio. If you have a hazard ratio more than 1, meaning that there is more likely chance of you to get TKR. If it is less than 1, then there is less likely chance for you to get TKR. So let's look at the results. So at the beginning of the analysis, they have 1.3 million people aged more than 45. However, 1.1 million was excluded because they do not have diabetes. So total is 196,000. So out of that, 70,000 was removed because of exclusion criteria. So there are two groups, the Metformin user and non-Metformin user. And then they perform this propensity-score-matched analysis, and they remove 86,000. However, more than 0.1 they remove, so only 93,000 left.
The 46,906 patients were removed, right? The non-users of Metformin.
This one.
No, the one above.
This one is control. This one is the.
Okay, fine. Okay.
So out of that, only 184 TKR in Metformin user, and non-Metformin user is 222, slightly higher in non-Metformin user. So we look into this one, matched cohort, meaning that after propensity score, this is your matched cohort. So we want to look at, the first is mean age. We find out that the mean age is around 70, meaning that it is population for knee osteoarthritis. Out of that, 222 TKR in non-user, 184 in regular Metformin user. And we look into this important ratio. So first, we have to identify the p-value. So the p-value is significant because it is less than 0.05. And then we look into the hazard ratio. It is 0.81. So if you remember, less than 1 is less chances for you to get TKR. Or in other words, there is 19% reduction of TKR rate in patient who has regular Metformin compared to non-regular Metformin. And how you translate the log regression is to the Kaplan-Meier survival curve. So if you look at these two lines, okay, the higher the line, the lesser for you to get the disease, or in this case, the lesser the TKR rate. So diabetes patient on Metformin has the lesser rate of TKR as compared to the non-Metformin user, meaning that Metformin user, non-Metformin user has a higher chance to get TKR as compared to the Metformin. And then they perform another analysis where they compare the number of prescription and their hazard ratio, and they found out that patient who has 5 prescription per year has the lowest hazard ratio, meaning that 26% reduction rate of TKR as compared to the 2 prescription, 0.89, meaning just 11%. So in summary of the finding, there is low incidence of TKR in Metformin group. There is statistically significant reduction, around 90% rate of TKR in the Metformin user compared to non-user, and there is an apparent dose-response relationship, meaning that the higher the prescription rate, the lower the risk reduction. So as for discussion, there are few studies who actually look into Metformin and knee osteoarthritis. One of the study is by Lu, and this is in Taiwan. They look into a very small sample size, it's around 968, and they also found that COX inhibitor plus Metformin has 26% reduction rate of joint replacement compared to COX inhibitor alone for the past 10 years. And then Wang, they examined 818 participants in patient who is obese and also knee OA, and they found out that there is significant reduction in rate of medial knee cartilage volume loss over 4 years, but there is statistically no significant trend towards reduced risk of TKR for the past 6 years. And then another study in Iraq, they looked into Metformin and meloxicam, and they found out that Metformin and meloxicam prescription result in greater improvement in pain and function compared to meloxicam alone in patient who actually has knee osteoarthritis within 12 weeks of prescription. The strength of the study, they use this propensity score matching, meaning that they compare apple with apple, orange with orange, so the comparison is quite good. They include a lot of factors as compared to previous study. They only include 1 or 2 confounding factors, but this one you have at least 3 major groups of confounding factors, and they have the indirect relationship of knee pain. So the problem with pain score is they are not in the secondary data, so they cannot analyze what is the improvement of the pain. So they use an indirect measurement where they balance it using the prescription of NSAID and paracetamol. So that is the reason why they include NSAID and paracetamol as their confounding factors. Limitation number one, because of secondary data, they do not know what is the duration of the metformin, the exact dose, the compliance. Okay, the pain score was not available. Lifestyle factor is not included because it was not in the secondary data. There is small number of TKR, and the interesting part that I would like to highlight is they do not follow up the patient who has knee OA then develop TKR, because they follow up patient who has diabetes and then develop TKR. So there is no direct relationship between that. So maybe this is one of the major limitation that I find in the study. However, future study we can do by seeing a patient who have knee OA and diabetes, and we follow up them by prescribing them metformin in the future if we want to do the study. So in summary, I believe this is a good study. Metformin does have a potential slowing effect or counterproductive effect in osteoarthritis, and the author suggests metformin may be repurposed as a disease-modifying agent for patients with OA. However, in my opinion, I believe we need more bigger studies that look into relationship between knee osteoarthritis, diabetes as well as TKR, instead of we follow up patient with diabetes and then the outcome is TKR. That is quite awkward for me now. So this is my last slide.
Can you go back to the strength?
This is one of the biggest study lah, because they use 93,000. I think that is why Nature accepted.
Published ke mana?
Baru je.
The second one included all the confounding factors which might otherwise affect the prescription of metformin, such as diabetic control, comorbids, medical conditions such as renal failure and heart failure. What does it actually mean?
Meaning that sometimes you also prescribe metformin in patient who has other comorbid. For example, in patient who has borderline diabetes kan, impaired glucose tolerance. In patient who has IHD, sometimes they prescribe metformin just to control the sugar.
But when you say the strength of this study, how does this become strength? This doesn't in any way help.
Okay, that is because they actually control the confounding factors.
So you're talking about the health of the patient in general?
No, for example, I took metformin and then Hamizi has IHD and I do not have IHD.
Okay.
So he will compare IHD patient with IHD patient and looking into the rate of TKR. Meaning that they control the one of the factors that could contribute to the metformin use lah. Yes.
Maksudnya dos yang ada acid itu sometimes dia tapi
Yes.
dia
Dia ada impact.
because of acid.
Dia ada impact glucose tolerance. So they want to look into that as well. Meaning to say that what they want is they want to control as much as confounding factor as possible.
Yeah. So the limitation, please, can you open the limitation? Okay. Some factors are so just all control. Yeah. So what I find, what we can comment is that whatever that you have mentioned here, not all cases of OA ends up with a TKR.
Yes.
That's one to say. The other one that was extremely relevant in this situation, instead of marking the TKR, maybe we can look at pain score.
Yes.
Pain score would be something that is more
Functional kan?
yeah, because you see, even in Malaysia, I do not know about what they do in Taiwan, right?
This one is Hong Kong.
Hong Kong, yeah, sorry, Hong Kong. But here we don't have the facility, the finance, the whatever limitation factors that we have. I don't think everybody ends up with a TKR. And I don't know about latest prescription of patients with diabetes, but metformin is still the first one.
Yes.
But is it still given as like first line? I heard recently that they are looking even
SGLT2,
yeah, some new kind of
empagliflozin, but that one is still second line. The first line, because the empagliflozin, they are the cardioprotective effect.
So when we are talking about metformin and OA knee, let's say for example, when would you suggest that we start metformin? I mean, if you are able to start,
Okay.
when do you suggest we start? You know,
So
for patients, is it which stage of OA would be beneficial? Is it from the very beginning?
Yeah.
So what I would suggest is, number one, we need a longer prospective cohort study to look into when should we start, because the animal study actually shows that if you perform meniscectomy, they have this chondroprotective effect. So should we start the patient in patient who has meniscus injury itself, ataupun in patient who has mild disease, for example grade 1 or grade 2, because the action is a chondroprotective effect. But there is one study in Iraq that looks into the pain as one of the outcome, and they are actually grade 2, grade 3. So we can actually look into that. But of course, there are only 4 papers that describe metformin in osteoarthritis. This is a new findings.
All those 4 papers yang supporting this research, they are not in diabetic patient.
Ada diabetic yang ini yang diabetic. Ini use metformin in also diabetic juga.
But for non-diabetic,
For non-diabetic.
can they still start take this metformin?
Oh tak.
So dia belum ada
Belum ada lagi.
yang buat
Prospective.
But that's the idea, right?
Prospective, yeah.
That's the idea of this paper, isn't it?
Yes.
Correct, right? So when do we start metformin in patients who don't have diabetes but have OA because of the chondroprotective effect? That's what
Yes.
they're looking at, right?
Yes, yes.
Yeah.
They want to do. They want to.
Yeah. The
use-
other thing that I want to ask is with regards to some of your slides did mention that they give along with metformin they give NSAIDs, right?
Yeah, this one is in the. This one. But this one also is a retrospective study. Semua ni there's no prospective study. Semua ni retrospective study. So we need a bigger number prospective study that look into metformin and knee osteoarthritis, not metformin in patient who has diabetes and osteoarthritis.
Yes. But that would be like major study, lah.
Yeah.